So case number 1, it's a 76-year-old male. He had, as past medical history, a stent on the RCA, not the LAD, but the RCA in 2017 for a positive exercise test, hypertension, dyslipidemia, and apnea. And he was referred for a coronary angiogram for another positive exercise test. You can go to the next slide. You can see the angiogram. Here is the left network, so there is a significant stenosis of the circumflex. And on the other video, you'll see the LAD, which is fine, and the significant stenosis of the diagonal branch. Next slide. Yeah. So if you see the first video, there is an eccentric stenosis of the mid-RCA. And on the next video, you will see that you don't see the stenosis anymore. So it's a really eccentric calcified stenosis. The last video shows the same, so we don't see the lesion on this run. So we decided to perform an ad hoc angioplasty of the RCA. There was first DES implanted after predilatation here, and we add another one just above to complete the result. And after the control, here we did a pot because we thought that there was a not well opposed. And here is the drama. You can see the control. This. So we really don't like to see this image in our cath lab. So what we did is that we rapidly inflated the balloon for occlusion. And the thing is that we didn't have kept the balloon inside the guiding catheter, so we had to ask for another balloon. And so that took a little time before occluding the artery. So
what size of balloon was it?
So the pot was with a 3.5 non-compliant balloon, which was maybe too big. Obviously too big.
Oh, yeah. And the stent in the mid-RCA was a 3.0, and then you post-dilated it to 3.5.
Yes.
And the proximal stent was also 3.0.
3.5. 3.5. Yes.
Okay.
So here you can see it's a type 3 perforation, no really doubt. And what comes next? So after the immediate balloon inflation, the patients quickly get unstable with hypotension. We performed a TTE that confirmed the tamponade. He underwent a cardiac arrest. So we performed CPR, emergent percutaneous pericardiocentesis that drained 40 milliliters of fresh blood. And we could treat the culprit that was happening now. So we performed a ping pong technique, which was first used for CTO, and as we know it very well, it was very helpful. So we were in radial access, so we had to use a second access, which was femoral. So while the balloon was still inflated with the radial access, we used a second guiding catheter with another wire in parallel to the second wire, and quickly we deflated the balloon to cross the lesion, and with the second wire we could pass a cover stent and treat the perforation.
You said you used the right radial, but you can also use the left radial. Was it impossible because you never do it, or because the patient was at cardiopulmonary resuscitation?
So I think
you go femoral.
When it's an emergency, femoral is very quick. It takes a few seconds. The access is really straight, whereas for the radial access, you have to go to the other side. You have to place the arm in the good position, and I think in this situation you must not lose any minute. So, and when we perform the angioplasty, there is always a radial and a femoral access that is ready. Whereas if we have to use the left radial access, we would have to prepare again to clean it, and it was not ready.
Okay, and maybe we also explain ping pong technique. I think by now a lot of people know, but it's still initially used in CTO, PCI, and now, I mean, it's definitely a very good option in corneal perforation. As you showed, you can immediately block the perforation with the balloon, and then you have your second guide free to maneuver independently. But just to explain it in more detail, so ping pong means you have a second catheter staying at the same ostium, and that can happen on the right or on the left side.
Yes, absolutely. I didn't tell this good enough.
And the other thing, you said you have the balloon already out of the catheter. This is usually something that happens when you have a perforation. And especially in this patient, I think nobody would have expected the perforation. I mean, it was a diseased vessel, but there was no calcified nodulus that you think could get pushed through the wall and rupture the vessel. The stent, I think 3.5 in a big RCA is not too big. Especially you put in a 3.0 and took a non-compliant balloon. So I think a lot of people wouldn't have never expected a perf. I would probably also have retrieved the balloon. But if you ever have a lot of calcium and you think you are at the upper end of the size, I usually, after deflating, I leave the balloon in place and I check just briefly 1-2 milliliter of contrast, and you would easily see a big perforation like you had, and then you can immediately inflate the balloon. And if you then use a ping pong technique, you sometimes, even in big perforations, you get away without pericardial synthesis because it doesn't even have time to bleed. In this case, you obviously lost a lot of time, and then therefore you already had 200 cc of blood in the pericardium.
Absolutely. This is the lesson for this case, unfortunately.
Yeah, but you check the next 200 times, I call it the safety check. You deflate, you inject a little bit, and then you can safely retrieve the balloon, and you have all the time. And the 201st time, you don't do it, and then that's your next perforation. That's Murphy's Law. That's how it is.
Yes, sure. So if we move to the next slide, you can see the advancements of the covered stent, which was pretty hard. We had to use a guiding extension because the profile was not that good. And if you go to the next slide again.
So just to explain for less experienced operators as you are, there is a lot of stuff going on here. First of all, we have the lead of the ECG. Then we have this S-shaped tube, which is the pericardial synthesis, going from subxiphoidal and then around the apex and then up to the proximal LAD. And then we have one Amplatz left, I think, that you did the intervention over it, which has the wire in and the blocking balloon. And then you have, I think, an EBU or something with the guide extension and the balloon of the stent graft. Is that right?
So it was a JR, I guess.
JR.
Or another Amplatz, but a smaller one.
So you can appreciate that the blocking balloon is up until your covered stent is adjacent to the balloon, and you just deflate and advance it. That's how short your deflation time is. And then you could also, if you need time to place the graft, you can also take the blocking balloon back and block the inflow in the proximal RCA. Then you have a little bit more time to place the stent. But it's tricky, and as you show, you can easily lose all your gear and equipment. And then if in a big rupture, if you have to rewire this vessel, it could be very dangerous because sometimes you don't even find the distal target anymore, and you end up outside in the pericardium with your wire. So I think the most important thing is to keep the hands down of the patient, because he starts moving and tries to take out your wire, and you lose the whole access. So first, make sure you keep access with the wire. Everything else is secondary. And then the second thing is the pericardial drain. and the blockage of the inflow, and then you basically have all your time to do the rest.
Yes. That's a very good comment, yes. And after the control, unfortunately, we thought the position was correct, but it was still leaking. So we had to put another cover stand. So the cover stand was a 3.5 of diameter. So we just advanced another one below the first one.
Why was it still leaking? Did you miss the spot?
It didn't seem, but maybe.
This is the typical finding. I think 80 to 90% of the grafts that I had to place due to a perforation, this is the result you get. So I learned two things from it. First of all, don't try to take the shortest graft, take a little bit longer than you would stent the lesion. Because at this point, it's not about short stents, it's about saving the patient's life. And if you take a little bit of a longer graft than you would stent, you're more likely covering the lesion, the perforation. Second of all, this one, I think I'm absolutely sure that you covered the perforation, but it's called endoleak. The stent usually is not flush on the wall because it's calcified. It's like a lunar surface almost, if you think about it in macroscopic views. And the graft, the PTFE layer, is not able to completely seal that rugged terrain, so it can bleed behind and then exit the perforation hole. So it's called the endoleak, and you will probably show solutions how to solve this issue.
Yes, that's it. So we inflated the balloon inside and waited just a little, but the leak was still there. So this is why we had to advance another covered stent.
On your RAO, it actually looks like the bleeding is coming from the distal end. It goes behind on the dorsal side. So in the image in the movie on the right, on the left side, you can actually appreciate, I think, that the blood is going behind the stent and then goes up and then out through the perforation.
Yes, you're right. So you can go to the next slide. So here is the placement of the second cover stent, still with the guiding extension. And the final result that comes next in the next slide.
Oh, sorry, it's on me.
Here. So the perforation is sealed.
That's another thing you have to know. I mean, but when you're in stress and you place rapidly a graft, and as I said, if you take a little bit of longer graft on the right coronary artery, is not such a big issue, but on the LAD and especially in the left main, you're excluding all the side branches. So this could be ending up in a new problem. Let's say you have a proximal LAD rupture, you place a graft and you overgraft the circ, patient can go in shock just because you're occluding a big vessel. This has been solved with puncturing through the PTFE membrane and create an orifice with Confianza or any penetration wires, Hornet 14, Warrior, something like that. It's not the issue here, but you have to think about that you're excluding all side branches.
Yes, sometimes you have no choice. It's life-saving to put the covered stent, so you have to deal with the infarction or the hemorrhage.
If you are really sure that it's an endoleak, you can also, instead of placing another graft, sometimes you don't have the grafts available because you used up two and you only have two, and your third that you might need is not available, or the graft sizes are too small. Another thing I believe you must know is to what size can you overexpand your graft. You might have a 5-0 vessel and only have a 3-5 available. Make sure you know to what maximum size you can inflate them, because usually you measure you estimate the vessel too small, then you have the endoleak, and then you cannot overexpand it without rupturing the PTFE membrane, and you're in big trouble. So these are things to remember. And if you don't have a graft and you believe that, or you're sure it's an endoleak, what you can do is add another drug-eluting stent, ideally one with very high radial force. The role model would be the Synergy Megatron, who has 2.5 times the radial strength of any other drug-eluting stent. And then you can post-dilate with the Megatron in the graft, and you have enough radial force to withstand the recoil, and that sometimes helps to overcome an endoleak also.
Okay, it's a very good tip. Thank you.
And of course, ultra-high pressure balloon dilatation is important. Again, remember, you have a rugged terrain and you place your PTFE membrane over it, and there is all holes in between where endoleaks can be created, and you can only flatten that with a very high pressure. So if you still endoleaking, take an OPN balloon and go to 50 atmospheres. Don't be afraid. It's a perf, but the pressure doesn't harm the vessel as long as your balloon is not oversized. So these are some tips and tricks to bail out from an endoleak.
Perfect. I think the next slide is just a little sum up of what could have been performed better for this case. If you can move to the next slide, please.
Didn't you not do any, I mean, obviously not at that time point, but did you discuss the distal RCA and also that step up at the ostium?
So what happened is that the patient was, after the cardiac arrest, the tamponade, we decided not to treat anything anymore. He was follow-up with his cardiologist, and he had no more symptoms. So we left things like this.
Okay, great.
Yes.
So the next slide is this here.
So yes, there could be a misevaluation of the diameter of the artery. Maybe it could have been assessed with intravascular imaging to help us with the assessment of the calcification and a better visualization of the diameter. And so what we missed for this case, as we said before, is the immediate balloon inflation with the balloon that stays in the guiding catheter. And therefore the hemodynamic instability came very quick. And so what we see also for this case is the utility of the ping-pong technique.
Great case, Natalie, as always, and also very impressive. I mean, it's a huge spilling, and I'm sure that you were shocked the first couple of seconds, and they're also good learning points. I interrupted you already a lot with comments. I hope you don't mind.
No, of course.
But I think we've done the discussion already during your presentation, and for the sake of time, I think we just jump to the next one.
Yes. So the second case is about a 65-year-old female who had just as a past medical history hypertension. And she came, it was, so this case was in another hospital, was performed by a colleague. So this woman came for a subacute inferior STEMI, but she still had pain. So this is why she came in the cath lab for a percutaneous revascularization. So she received aspirin, heparin, Cangrelor, and ticagrelor. And you can move to the next slide so we can see the angiogram. So on the left network, there is nothing significant. And you can see the other video that shows the acute occlusion of the RCA. So here it's basically a STEMI. You can move to the next slide.
Did the patient have ST elevation? Because
yes,
the occluded vessel is collateralized well, and sometimes I see acute occlusions without ST elevations when you have such nice collateralization.
So yes, she still had the STEMI on the electrocardiogram, and she also still had some pain. So these are the two reasons why she had the PCI at first.
Yeah. I have a little bit difficulties moving,
So for the crossing of the lesion, he used cyan black, so polymeric jacket wire. He performed thromboaspiration and stented with one drug-eluting stent. And the result, you can see that there is a distal embolization in the PDA. So he decided to perform thromboaspiration in this branch, which is, we can discuss about it. The next slide.
There is also a huge thrombus in the distal right coronary artery, which is
Yes.
moving backwards. Now you can see it and it goes upwards. So
Yes,
it moves.
absolutely.
Can you see my mouse?
Yes.
So
we do.
it's about here. I mean, you know it, but for everybody else, and now it moves up here. Huh? So it's moving back and forth. I think this is a thrombus.
Mm-hmm. So he wanted to remove a part of it, and
You
also,
wanted to remove this one here.
yes,
Mhm.
absolutely. So after the thromboaspiration, you can see here the control. So there is a distal perforation, which is due to the polymeric wire,
What type of wire was it?
cyan black. So
Which
it's
is,
not
for everybody who doesn't know, Asahi wire, non-tapered, polymer jacketed, low tip, so-called benign wire. We use it for transeptal crossing, septal surfing. But as you see, every wire can have a distal perforation. And
Yes.
of course, with polymeric wire, it's more likely because they have less friction. They kind of move themselves sometimes. And if you're in a very small branch, it's like being in a microcatheter. The wire is restrained. It cannot move sideways like in a big vessel. And then the tip load becomes excremental. It can be 40 times the tip load. And if this is a tip load of 1-point-something gram, it can be 40 gram. This is an Astato penetration wire. So it's very, very dangerous to have your wires too distal in small branches.
Yes, but I also do the same when it's something subacute with the thrombus is already organized. I think it's the choice was good, but problem is that it advanced too far, and so this is what happened.
Yes, and also I don't like these loops. I mean, I know a lot of interventionalists, they love when the workhorse wires loops early and they just shove it down. But it is more likely to do distal perforation with the knuckle or with a loop than without. I usually direct my wires with the tip looking forward, and you only do knuckle wire when I travel subintimally.
Okay.
It's so-called safe, but I've seen a lot of distal perforations pushing this loop too far distal.
Mm-hmm, I see.
I heard, I didn't test it myself, but on a cyan blue workhorse wire with low tip load, when you have this loop, the loop kind of has an outwards or a radial strength.
Yes.
When you bend it, and this could be at the level of a penetration wire at some point, and therefore if you shove it too far distal, it could be dangerous.
Yes, absolutely. So the loop is fine if the size of the vessel is big enough, but in small branches, it's not nice.
Correct.
So here is another distal perforation. So he proceeded to an immediate balloon inflation and waited to see if it was sealed, but it kept, the leak was still there. So, and also after the balloon inflation, the patient had a vagal reaction. The balloon gets displaced, and she had a tamponade as well. So he performed pericardiocentesis, and he quickly punctioned for a second access to be able to treat the perforation while the balloon is occluding the artery, so like before. So the idea was to have a balloon inflated and to perform a distal embolization, but slowly and with time, because he had the ping-pong access. So I'm just making a little summary of the device and that we can have for distal embolization. So you can have either coils, gelatin sponge, subcutaneous fat, and something that's less well known, it's microvascular plug. So there are also other devices available, like a thrombin, or maybe you have another idea, but you should use what you have in your cath lab and also what you know how to use it to be very quick.
Of course, I have another idea, but unfortunately it's not mine, but it's something self-built. I've seen it in a case. So, I mean, if you do PCI, coils having on the shelf is mandatory, as well as covered stents. Subcutaneous fat comes with the patient, sometimes more, sometimes less. I have altogether in my career 6 cases, and they all worked, and I love it. Could be tricky, especially when you're in stress, to get that fat tissue into the guide and how to get it advanced, because fat sticks to everything and floats on the water. So this has to be trained dry, I mean, or on a bench before you actually use it in an emergency. Resorbable gelatin sponge is a solution. Thrombin, I think it could be dangerous because it can float in other directions, and all of a sudden you have the bigger vessel closed, or if it goes back, like the thrombus you saw, it was actually going up the vessel. So you can imagine that it goes back and into a side branch and includes maybe the PL branch. So in my experience, this could be dangerous. And microvascular plug, I have no idea. But the fifth solution, what I saw is they took a regular PCI balloon and cut it completely through behind the distal marker.
Yes.
So you have your tip, then you have your distal nose of the balloon, and this works like an umbrella. And then you put the whole thing onto the wire and you just advance it at the very end. And when you retrieve the balloon, the tip of the balloon and the nose of the balloon stays in the vessel and occludes it. It's a small piece of plastic, but it works. And if you have nothing else, before losing the patient, this could be a neat solution.
Yeah, it's a nice option. I mean, when it's catastrophic, whatever you have is fine, I would say, as soon as the patient is fine. For the thrombin, so you can do it securely if you perform like septal alcoholization, in fact. So with a balloon that occludes the artery while you inject.
But you need an over-the-wire balloon.
Yes, absolutely.
But yeah, absolutely. I think it's mandatory. I don't have experience, but just as a concept, I think it's mandatory because I would never do it over a microcatheter because it can spill back, and that will be a really big problem.
And it's the same for gelatin sponge. Okay, so if
one thing that was, I think, very specific when you go back to your movie, you can appreciate that the contrast, as you said, is staying there. So it is a hematoma in the myocardium or in the pericardium in the fat tissue. And in my experience, when you have this hematoma, the first symptom the patient has is chest pain, and then he starts feeling bad and vomiting. So it's interesting. I think this is a very specific sign that the patient has nausea and starts vomiting when you have these much more than if it's freely draining into the pericardium.
And do you have this for any territory or?
Yes.
Just, okay.
Yes. And then, of course, it looks localized. You can say, okay, it stays, the chondra stays, but whatever can happen, especially when patients are hypertensive, is that secondary, this hematoma then ruptures and opens to the pericardium. And I think this was what happened in your case, and then you have a tamponade. So it could be a 2-time event.
Okay, yes. Here is the pictures of each device. So microvascular plug, we're going to see it later. So for distal embolization, what I wanted to insist in is the choice of microcatheter, because the inner diameter must be big enough in order to receive the whatever you choose, so coil or gelatin or whatever. So this is why you cannot choose any type of microcatheter. One that's large enough is the ProGrate, and some coils can fit also in the fine cross, but it's not all the coils.
I think excellent point, Natalie. This is absolutely crucial. The best coils do not help you if you cannot bring them to the perf site, and you cannot do it with any of the regular interventional catheters like the Asahi Corsair family, the Turnpikes from Teleflex, you name it. All the microcatheters, they are for 14 wires, and the coils, most of the coils don't work. I think there's Evo 3 coils that go through these regular microcatheters. Either you get those coils, or if you take, for example, the Terumo coils, which are very nice because you can detach them electrically, so it's very well controllable. For those, you definitely need the ProGrate microcatheter. And I had this experience. Yes. I had the coils, but I did not have the microcatheter, and I was a little bit embarrassed when I tried to get the coils feeding in the microcatheter, and they wouldn't go.
And what did you do then?
Fortunately, I had an interventional radiologist in the other room who had the ProGrate. So he helped me out. Otherwise, I don't know. I mean, it was not too distal. Spontaneously, I would think about a 5 French guide extension and then try to get the coils down. But again, there is a tube coming with these coils. I mean, you could use those in an emergency, but this is not a microcatheter. It is hard plastic. It's not rotatable. It has a sharp tip. So make sure when you go to your cath lab tomorrow, check your coils, check the sizes, and see if you have a microcatheter to deliver them.
So next slide. So you can see that he chose gelatin sponge because he did not have any coil in his cath lab, and he asked to an interventional radiologist what could he use, and so gelatin sponge was the only device available. So how did he perform the embolization? There was still the cyan black in place. He advanced a balloon for occlusion next to the cyan black, and also he advanced the gelatin sponge through the ProGrate to have enough lumen. So the gelatin sponge, if you saw before, it's like a liter square of sponge that you cut into pieces, and you mix it with some water, and then you put in a syringe and you inject it distally. So it's quite easy. The thing is that you really must inflate a balloon to occlude the artery before, otherwise it can go back. That happened to a colleague on an LAD, and it was really bad.
Yes. Another thing, delivering coils, I mean, it's a decent microcatheter is mandatory. If you don't have it, you could also use the aspiration catheter, most likely. And the third or a sixth idea, he could just put back the thrombus that he aspirated into the vessel. It would also occlude.
Yeah.
Maybe.
Can be an idea.
Okay, but this is the more recommended way, and it looks, at least this is the other thing that can happen. You know, you occlude the proximal entry into the vessel that is distally perforated, and it's occluded, but unfortunately you have a collateralization. And remember, this vessel was initially occluded, and it came completely retrograde through septal collaterals. So it could be that it's still bleeding from the septals from the left anterior descending. I assume that's why he did this shot from contralateral to see if there's any collateral filling and bleeding.
Yes, that's a very smart idea. So final result was fine. Everything went well. Today it's good complications, but good evolution as well.
Yes, and also it's nice you don't have any coils that people ask
Yes.
you for on the chest X-ray. And usually when you do fat embolization, the vessel is completely recanalized when you do a checkup 3 months later.
Absolutely. So what's nice about gelatin sponge is it's that it's completely resorbable. So yes. So this is just the algorithm for management of coronary perforation. I just wanted to insist of the prolonged balloon inflation at a very low atmosphere. So they recommend to do it for distal perforation for at least 10 minutes. For an interventional cardiologist, 10 minutes, it's much too long. I don't know what you think, but time is really, really slow. And also what I want to highlight is that distal perforation can be silent during a few hours, and then the patient gets hemodynamically unstable, but like 4 hours later. This is why they recommend to repeat the TTE.
Absolutely. As I said, the distal perforations are usually slow draining perforations, so they can take a while until 200, 150 ml of blood is collected in the pericardium and the pressure starts going down in some patients. And also it could bleed into the pericardial fat or even into the myocardium and then rupture secondary, maybe if the blood pressure goes up and patient comes unstable later. That's why we do final images and make sure that you have the entire heart on the screen and also inject prolonged and also do the cine a little bit longer and check for distal perforations. Absolutely critical. This algorithm is, or the classification is not the Ellis type classification, right, of coronary rupture. This is
it is. Actually, it is. Yes.
Okay.
Yeah.
Okay. No, sorry, I saw type 5 is, no, because type 4 is cavity, CS stands for cavity spilling, so it's a perforation spilling into the right ventricle, the left ventricle, or coronary vein. Mm-hmm. We just published 3 cases, I think a month ago, with 3 type 4 or type 3 CS perforations in each of those cavities that I said, and we left them as they were, and the patients came back 3 months later, and this fistula, what it is at the end, closed spontaneously. So it's really interesting. One, yes. I was sure it will stay open, but it closed spontaneously, and there's no action to be taken on these perforations. How can you check if it's perforating in a cavity? You can inject SonoView that you know from your echo guys, and then you do an echo and you inject the SonoView into the intracoronary, and then you see where it's spilling. If it's going in, if you see it in the right ventricle, it's spilling into the right. If it's in the left, it's spilling in the left. And in our case, we saw it coming out from the coronary sinus. I mean, eventually all the blood comes out from the coronary sinus, but then it's more timing. Once you inject and it comes early, then you know it's a coronary venous fistula. So that's how we checked in our case, and then you can leave it before using coils and everything. All right.
And so the learning point for this case is that a polymeric wire can be a weapon. So if it's possible and appropriate, you can exchange it. So as soon as I can do it, I change the wire. You must know the devices that are available in your cath lab, and you must know how to use it, because when you have an emergent situation, it's not there that you learn how to use it. I mean, you have panic, you must be quick. So it's really stressful. And also, so the pericardiocentesis kit must be nearby and available at all time.
Absolutely true. Again, excellent case. Just one comment. You said 10 minutes are a long time for an interventional cardiologist.
Yes.
This is true, except if there is a CTO involved. It's not a long time.
This is different. I mean, for a CTO, you're doing something. You're
Yes,
not
that's
waiting.
true. Just waiting is always too long. That's true.
That's it.
Okay, Natalie, I think for the sake of time, we go to your last case. I'm looking forward to it.
Yeah, so last case, it's a bit longer, so I'm going to try to do it quicker. So a 73-year-old man who had bare metal stents on LAD for a STEMI in 2002, and he consulted for de novo angina. First electrocardiogram, if you click, you're going to see it's a ventricular tachycardia.
Oh.
Yes, your turn. So there was no success of intravenous amiodarone, so he had an external shock. That led to the second electrocardiogram, if you click, which showed an interior scar. So after wake up, the patient remained stable with no pain, and so he was surveyed in the ICU. That showed troponin level, so he came for the coronary angiogram. We are going to see only the left network because it's a left dominant, so I didn't put the right. You can see that there is a significant instant restenosis on the LAD. So it was a Friday afternoon. I thought, okay, fine, very quick, balloon stent, and I'm home. But unfortunately, it's absolutely not what happened. So just take a moment to look at the branches because it's important for what's next. So the stent is on the proximal part. You can see afterwards that there is a small diagonal branch, the second diagonal, which is bigger, and then the distal part of the LAD. So we can...
Sorry, I didn't understand. This is the native vessels. You did not do
Yes.
anything at this point.
At this point, no. It's just to show you what caused the ventricular tachycardia. But I treated it, of course. But it's just to see the anatomy, because if you see where are placed the diagonal branches, you will better understand later what happened.
Okay, all good.
So we can go next. So I performed the pre-dilatation. I implanted the 3.0 DES, and the result is here. So there was a dissection at the end of the stent. So I thought, okay, it's not a big issue. I put another stent, but it's not what happened. So here you can see the inflation. There is still an under-expansion of the stent.
Oops.
And what happened there is that when I deflated the balloon was trapped in the under-expanded stent. So I couldn't retrieve it. So it was much more calcified than what I saw. So at this stage, what can I do? You can see the options if you click. So I had the idea to, of course, I retrieved the contrast and into the indeflator, and I tried to inflate again and deflate, but nothing happened. So I had the idea to put when a rota burr is trapped, so a parallel wire to advance a little balloon next and to inflate a small balloon to try to displace the balloon that's trapped. There is the option also to make a high inflation and burst the balloon, but it's really not what I would like to do at first. Maybe to make a perforation with a CTO wire, but the problem is that the balloon was already half deflated, so it's very risky. Other solution could be to cut the shaft, advance guide extension very far, and try to pull very hard and retrieve all the material, but I really did not feel confident about it. So maybe, Gregor, you have another idea?
Sorry, I didn't quite understand. You placed the second stent.
Yes, below.
The stent was underexpanded, or this is the stent balloon?
Yes. So I placed the stent was underexpanded. I deflated the balloon of the stent, and the balloon got trapped.
But did it deflate completely? It looks like.
Yeah, it deflated completely, but as the stent was underexpanded, I couldn't retrieve it because it was trapped.
It was pinched.
Yes.
No, because your answer 3, balloon perforation, the balloon is completely deflated. You will not make the profile smaller when you perforate into a deflated balloon. Also, I had a case with a stent balloon that did not deflate. Actually, this is 4 years ago, and the balloon is still up in the patient. I have a chest X-ray, and you can see the balloon still full of contrast. It's in a CTO, so it doesn't care. It was closed before, now it's closed with a balloon. But in this case, I tried to puncture the balloon from the backside with a lot of different devices. The backside of a wire, the Confianza, a Hornet, an Astato. I took even a Stingray wire, which is like a needle. I could not penetrate the balloon. Also, I took the tip of a syringe, which is cut, so it's sharp as a knife, and put that on a wire and went with the guide extension, safe, close to the balloon, tried to puncture, it won't puncture. And then eventually I did some bench testing. And from the bench testing on also the balloon manufacturers, I know why it doesn't work. Because if you have the balloon, the two shoulders, the proximal and the distal shoulder, the material is much thicker than in the rest of the balloon. So it's about 3 times the thickness of the rest of the balloon, and you cannot puncture the plastic there. And also, if you try to puncture, because it's on an angle, you always slip off with your wire, and you cannot puncture the balloon from the backside. There's 2 solutions for that. Either you come somehow from the side. So you could pass ahead and maybe have a steerable microcatheter and try to puncture the balloon from the side. This works, but only with a Stingray balloon because it has a needle. Mm-hmm. And the more common solution is take a guide extension, take scissors and cut the top couple of millimeters, because there is some braiding in the guide extension, and you expose the braiding, and you can go on the shaft of the balloon. So you have to also cut off the hub of the balloon. Then you place your cut off guide extension over it, and you push it into the balloon, and then you start turning it, and the braids will actually eventually rupture the balloon. There's a couple of cases published, I think, or even reported. This is the only thing you can do if you have an undeflatable balloon. However, this is not the case here. So in this case, simply as it is, I think 1 would also not work, because if you go subintimal, you are outside of the stent, and if you then inflate a balloon, you will compress the stent onto your balloon and it will completely lock it. So I think I would have done solution 2nd first. Just make sure your balloon is very well deflated or de-aired and completely filled with either saline or contrast, and then you just go up. The ruptured balloon doesn't help at all. It makes everything worse, because then you have plastic pieces laying inside the stent and it gets even more entangled. However, these balloons, they go well over rated burst pressure. So I'm sure if this is a stent balloon, you can go up to 22 atmospheres, and your likeliness that the stent will eventually expand at 20, 21 is very high, and you get free of your issue. So I would have done 2nd.
So there was 2 things. So the parallel wire was not to do an ADR. In fact, it was really to be in the stent and next to the balloon. And the other thing is that I didn't want to inflate the balloon too high, because I thought at first that the first stent that I implanted was big enough, but as it created a dissection, maybe I thought it was too big. So I thought then, okay, if I inflate too much the balloon, I'm going to have the same afterwards, you see?
Yes.
So what I chose, in fact, at first, it was to, I took a parallel wire, and I tried to advance it next to the balloon. So you can go to the next slide.
Just another solution would also be you break off the hub and you take a guide extension and put it very close, or you push it forward and you pull the balloon back. It helps a little bit protecting the proximal part of the coronary, and sometimes you can retrieve it like you would do on stock rotor.
Yes, but when you do this, right, you pull also the wire.
Yes, everything.
Yes, and problem is that when like this stent was underexpanded, so I was afraid not to be able to cross with another wire at all.
Sure.
So I tried with this parallel wire, but I couldn't advance next to the balloon. So then I called my chief, Eric, for some help. And so he said, okay, don't worry. Let's try to enhance the support with a microcatheter. So to try with this parallel wire, but just advance the microcatheter on this parallel wire, and let's see if it crosses next to the balloon. And what happened is that...
You have two stock devices.
Yes. So not really this, but like the balloon was stocked, and so we advanced the microcatheter over the wire without any wire extension. And so the wire, because there was a lot of friction, advanced, but not next to the balloon. It got in a branch, in a diagonal branch. And so as I was advancing the microcatheter, the wire kept advancing in this branch and did not stop until it made a perforation. So I had another complication, you see? So now we had to be quick. So the perforation seems to be in a vein. So maybe, as you said before, we could leave it this way, but there was also some contrast that with a tattoo staying next to this like sort of vein, so we were not comfortable leaving it this way. So now we had to be quick, so treat the perforation and then go back to this.
But where does it come from, the perf, the bleeding? I don't see it.
You will see in the next slide, I guess.
Is it behind the ECG box?
Yes,
there?
It's behind the ECG, exactly. Maybe we can see it after more precisely when we treat it. So how should we treat this perforation? Like leave it this way, prolonged balloon inflation, covered stent in the LAD, distal embolization. What do you think?
Leave it.
Okay. So we decided to perform a distal embolization with the plug. So at this moment, Eric told me, okay, don't worry, it's very cheap. In fact, it's very expensive, but it's very practical and easy. So we have to advance it via a microcatheter, so a ProGrid as well, because it's big enough. Then you advance the device. It's a plug that you unscrew. And then you can, before unscrewing it, you can obviously check if it's well positioned. And when you're sure of the position, you just unscrew and it's lived. So it's very simple.
Like a PFO occluder.
Absolutely, that's it. So the ProGrid couldn't cross, so we had to dilate the stent. And here you're going to see on the next slide the placement of the plug. So there is first a checking of where is the perforation. So you can see it better now?
Yes. Mm-hmm.
And the next video is the advancement of the plug. You can see it that we retrieve the ProGrid and the plug is in place. It's really tiny.
Mm-hmm.
So the perforation was sealed. We decided to explode the balloon to be able to retrieve it and to expand the stent. And there was no complication, no reflow. And so after that, we were here with a wire in place, an underexpanded stent, and we decided to perform IVUS to better assess what's happening in this artery. So you can see on the IVUS, so proximal to the stent that's underexpanded, that's the first stent is also underexpanded, in fact. So there are some calcifications, it's the stent in stents, and there is a clearly underexpansion.
Yes, here.
So at this time, we decided to perform some shockwave.
Maybe for some in the audience, I mean, you marked it nicely on the left side. So this is the underexpanded stent that caused the complication.
Yes.
And this here is the stent that had this edge dissection. And this is how big the stent should be.
Absolutely. So we did the post-dilatation. We performed the shock wave in the stent, 2.5, an OPN balloon. We had a nice expansion of the balloon and a 3.5 non-compliant balloon in the proximal part of the LAD. And after you're gonna see the
so
expansion.
you were unable to retract the stent balloon, but you were able to advance the IVUS and shockwave through
No,
it.
so the IVUS was above the underexpansion.
Okay.
It was really just inside the proximal part, just to see what's in this artery, what's inside this artery.
It would not cross the
No.
Basically, it's a non-expansion. I think it
Yeah.
completely stayed put. And then shockwave 2.5 went through the stent.
Yes. So we don't know what happened with this balloon in the stents, really.
Usually when they rupture, this is more frequent, that you cannot retract. Because then you have some tears in the plastic and then it entangles with the struts. And it could be that it ruptured early, so it was non-expanded at this middle part, and then you cannot retrieve it, obviously.
Yes.
And also they're very well crimped. Some of the latest generation stents, you cannot get the stent off the balloon, even if you try hard with your fingernails. They're really, really well crimped. And this is also an issue, that you cannot get the balloon out. Also, they're puffed, I think that's what they call. So they inflate the balloon slightly after crimping, that the stent, the balloon like pillows between the struts and makes a three-dimensional structure that the stent holds even more to the balloon. And you can imagine if it's not expanded at all, then it's completely interlocked.
Yes. So here you can see this is the balloon inside the underexpanded stents. So we have a good inflation.
Do you think the shockwave made a difference, or would you have achieved the same thing with OPN at 50 atmosphere?
Honestly, we don't know, but I think due to the high amount of calcification, due to the fact that the stent was underexpanded, we did not have anything to lose to perform the shockwave. As soon as it crossed the lesions, to me, I like doing this, using this device, because it really modifies the plaque and you don't lose anything to do it. It's always beneficial, I think.
Yes. And you don't have any other options. I mean, you can go 50 atmosphere or shock, which is acoustic 50 atmospheres. You can rotate the stent away, but it could be dangerous. You could do orbital atherectomy. This is all off-label. Cutting won't work because it's armored with the struts. Scoring won't work. So that's basically the only two options you have. There's two papers about underexpanded stents and shockwave. One is early in your case, like in freshly implanted stents. It works not as good or as efficient as plain IVL, because we believe that the cage of the stent absorbs a lot of the acoustic energy, and you have less energy beyond the stent, so it works less than pre-stenting. And the other one is in old stent, and there we see that old stents also works less And if you have dual or triple layer stent, it works even less. So supporting the idea that the cage absorbs a lot of the acoustic energy of the shockwave balloon. And also Alex, Achim and myself have published a case where we did shockwave to a polymer drug-eluting stent, and we did some electron microscopy analysis, and we saw that the polymer actually gets disrupted. So it also destroys a little bit the stent. I mean, what we learned from this case, lesion preparation is everything. I'm sure you're tempted to just add another stent if you have a distal edge dissection. I think a lot of people would not have prepared the lesion again, but this case nicely shows lesion preparation is absolutely key in our profession.
Yeah, you absolutely got it. This is 100% the comment that I wanted to make, and it was going to be on my next slide. So it's an unexpected complication in an apparently simple instant restenosis. What I learned is that we mustn't underestimate the calcifications, because if we relook at the angiogram, we can see that it's calcified, but at first I really did not see it. So there is a utility of the stent boost to target the calcifications. Also, we can discuss about using intravascular imaging. And also now what I do very often is when I have an instant restenosis, I use a cutting balloon to predilate, because it's more stable in the artery. I know it doesn't work if it's really calcified, but it's for the preparation of the lesion, I have much more better results.
So, Nathalie, absolutely fantastic, like always. We should have you present every month. Great cases, great presentation. I think we have to end here because our airtime is already over. Hope I see you all in a month, in December, for the Christmas session. And I can only say thank you again to you, everybody watching us, Nathalie, and see you in a month. Have a good evening. Bye-bye.
Thanks a lot. See you soon. Bye.